Dear friends, the Maharashtra chapter of RSSDI recently held their annual conference in Pune. Dr. Vasant Kumar, who is the president of the national RSSDI, delivered the presidential oration during this conference, and we are happy to provide this oration for your listening pleasure. Thank you.
Whatever I am going to talk to you, it's nothing new to you. It's only that I wanted to put request to all of you to remind you sometimes about our responsibilities, both as a professional doctor, also for the organization that we belong to. We are not just the doctors who sit in the clinic and see the patients who enter our rooms. So we have taken a bigger responsibility to do something for the society. If you see in the last 20 years, there is a lot of turmoil that is happening. There is a lot of mistrust between the society and the doctors who practice modern medicine. It's not universal, but majority of us are concerned about it. Why are the society behaving like this? Why there is some kind of violence here and there? Why there is so much of belief in some systems which don't really provide the proper management? Why is this happening? But please remember, for all these reasons, you just can't blame the society. Society always has a largest place. You can't keep on saying that no, people are against doctors, they are doing this and that. That doesn't help us. We have to see what are our own shortcomings. We have to see how we can do better in future, how we can convince our patients, how we can gain their confidence and their trust. That is very important. Otherwise we fight and IMA says something, all of us want to, grumble. That doesn't happen. Please remember, I am taking this opportunity to tell this to you. And of course, we are talking about diabetes in Indian patients, so obviously you know the kind of subsects we have. Indians are totally different, even amongst South Asians, not only compared to the Caucasians, Africans, and East Asians. Even in South Asia, we are different. So we know that we have insulin resistance as well as beta cell dysfunction, which I will also talk to you. Many of them have a strong family history, and you see a lot of them at a younger age. Diabetes happens at a younger age, and they also have high complications, including cardiovascular disease. And of course, I don't need to tell you about the kind of diet that we eat. We eat different diets in different parts of the country, depending on the social, economic status. But all of us eat too many carbohydrates and also bad fats, which I will talk to you. So, this is what is happening exactly. So, we need to work on all these issues if you want to win the war against diabetes, just because we are different. This is one of the slides which show that if you see at the end, 50% had poor diabetes controlled as measured by HbA1c, and 54% had late but severe complications. The reason I put this slide here is 50% had poor diabetes control as measured by HbA1c. So it's not even a proper statement. How many people get HbA1c in this country? Do you know? What percentage of diabetic patients do HbA1cs? Rural, urban, wherever they are, in the government sector, private 20%. You can make a wide guess. Is it 5%? Is it 10%? Somebody was telling me the other day that there are many Indian diabetic patients who never had HbA1c done throughout their life. And I agree to that point. I mean, I don't think there's an exaggeration on that point. But this is a fact we have to accept. So we have to understand this. We want to treat all our diabetes by doing HbA1c. Okay, go ahead, see that HbA1cs are available to everybody. But that's not going to happen. So we have to treat our diabetics even without HbA1c. I mean, it looks very funny that RSSDI president makes this statement. But it's There are a lot of things in life which appear, this is one slide that all of us know, how we still stand, fortunately, number two. So we have been experiencing rapid socio-economic progress, urbanization, and we also have, so we are taking a lot of global burden on diabetes. If you know, we are almost 1/5 of the global diabetes burden is in India. So studies from various locations in our country did show that the diabetes is prevalent everywhere, whether it is east or west, north or south, or central India. And remember, it's not only in the urban population, also in the rural areas. Things have changed over the years, you know that, what kind of changes that took place in the rural areas. So all this happens because of the change in the lifestyle of the people. If you see the urban and rural divide, although a lot of rural areas have urbanized, but still we have about 70% of so-called rural areas. The reason that I have put this slide here is, when you're talking about the presence of doctors, it is exactly the opposite. 70% of the rural areas have only 10% of the doctors available. They are all, 90% of them are in the country where 30% of Indians are living. I am saying doctors, I am not even saying specialists. Even the simple MBBS doctors or maybe internists, very few are available in the rural areas. So you want diabetes to be managed by specialists? What happens to you? Please put this question to yourself today. You think the specialists are going to manage diabetes in this country, especially in the rural areas? So I have more questions than the answers, unfortunately. So there is a lot of disparity in the availability and affordability of diabetes care, as well as low awareness of the disease. So naturally, the glycemic outcomes are going to be really bad. They are far from ideal. You know the reasons. We know that lifestyle modification is a very effective tool for primary prevention, not just managing diabetes, for primary prevention. And that is what is urgently required. We all need to work, see how we can reduce the diabetes burden by preventing itself. You know, there are millions of people are waiting to become diabetics right under our nose, who come to our clinic. But do we talk to them about it? Many times the diabetic parents come, their children obese, young adults come into your clinics. They are all potential diabetics. One or two words from you might give some importance. You know how people spend money for diabetes care, out of which, if you see, 35% according to this particular study, which is not an Indian one, where they spent 35% for hospitalization and manage other complications. This is what happens, obviously. So we have a lot of social barriers. It is nothing that you do not know. A lot of financial constraints, and there are so much social, cultural, and religious stumbling blocks to manage diabetes. We have a system where people fast. We have to encourage them to fast. Recently I had, Dr. Zargar was there with me, where we spoke about Ramadan fasting. So it's our duty to see that most of them do it, because faith is one thing that you cannot say no. But we have to see how it is possible that they can do it. You talk to them about science and you say that you can't do it, they just run away from you and they follow it. It's better you have a negotiation with them and see how they can do the fasting. That is what the life is about. So you know, in developing countries, youngsters who are diagnosed newly, they have a lot of issues. You know, they are overconfident, they are irresponsible, they don't even tell others, they have a social stigma, and they don't want to spend money for medication. And then remember, in India we have a huge young diabetic population. When we say young now, we say 25 years and below. And so we know that the diabetes is increasing amongst the young people, especially in South Asia. And this is one of the slides that I'm sure most of you have seen. It's a European study where it's published in the Lancet, where you have different kinds of clinical subsets of diabetes patients. Insulin resistance, insulin deficiency, mild disease, like this. But I will also see how we differ in India. This is the slide by Mohan and Anjana, which was published. So in this, if you see, what is surprising is that we have insulin-resistant obese diabetes, where we worry about the lifestyle of the people, sedentary and overweight people. We also have about 12% who have combined insulin resistance as well as insulin deficiency. So that means we have quite a sizable number of our type 2 diabetic patients who also have beta cell dysfunction. You have a case to deal with obese type 2 diabetes. You have an issue where you have to treat many of these young, lean, sometimes malnourished diabetics. They are so-called type 2 diabetics, but they have significant insulin deficiency right at the time you diagnose them. So then it's a big issue for you. It's not going to be easy. And many of these young fellows who develop diabetes at a young age, it's very difficult to handle them, if you see. Especially if they belong to the rural or semi-urban areas. They're less educated, they don't listen to you so easily. And these are the people who are the future breadwinners, and we expect them to live for another 40 years of some good quality of life. But then how is that possible to handle these young fellows? Many of them have bad habits. Smoking is a big issue, along with alcohol. Many of them drink illicit alcohol in this country, you may be aware. So these are all the issues. So we want to make our India diabetes care capital of the world. It's a beautiful sentence and a beautiful phrase, but can this be a reality? Is a question that I am asking you. So we also know, but generally these are the things that which I already mentioned, how Indian diabetics are different. Some of the things, you know all of them, but one thing that worries me is still there is illiteracy and low literacy, and there is poverty very much lurking in every part of this country, whether we blind ourselves to it or whatever. And do you know that today diabetes, if you see in the urban areas, you see it more in the urban slums, not in the rich areas comparatively, because urban slums are thickly populated. Millions of people live in all the slums all over metropolitan, even the smaller cities in India. That is where the diabetes is. That is where the neglected diabetes is. Neither they get screened, nor they take the medication, because most of them have to spend money from their pocket. That's where they live. And how do we handle these people? They need to go to the government hospital if at all they go. But when are they going to screen for diabetes? I don't know. And another problem is we have a huge, what is called double disease burden in this country. We still have communicable diseases, which are unfortunately more common with people like uncontrolled diabetes. And you can imagine if they are living in urban slum, poor hygiene, bad water, crowded situations, uncontrolled diabetes. So you see infections there, whether it's gastroenteritis, foot infections, pneumonias, even tuberculosis. So how do we handle this? I mean, it's an enormous burden if you're talking in general. And people have a lot of misconceptions about diabetes, seizure, and other issues. And the kind of street food that we eat, everything is not in this slide. The reason that I have put even those foods that you see in the packets, we always conventionally blame the Western junk food, which is causing high cholesterol, diabetes, overweight. It is true. But in Indian setting, if you see, many of the poor people, lower middle class people, eat street food, which is even more dangerous than the Western junk food. I am making this categorical statement because I know the kind of food that is available across the street. It is a lot of sugary items, and then do you know a lot of trans fat is used in all the foods that you eat across the street, whether it's a dosa, samosa, or biryani, and trans fats are banned in most of the developed countries. We have not done it yet. We have not even limited the trans fat content amongst the foods. The government has not been doing it. And it's an important thing for us to do it because cardiovascular diseases increase, bad cholesterol increases with trans fat. I'm sure you all are aware about the trans fat is nothing but, it's made from the palm oil by hydrogenating it. And it is used left and right in all food that you eat. All the processed food that you eat, the biscuits that you have has trans fat in it. And imagine what will happen if a child starts eating it. Coming to the point about role of physicians, so we have a huge role to play. We have to prevent and we have to see that we detect them not too late so that you can prevent the complications by a good control of diabetes. I said strict control of diabetes. I don't really know what strict control means. So how can we do this with limited resources is a big issue. So can we practice the evidence-based medicine which we always learn in these four walls every time, morning to evening? We talk about science and science and science. We talk about the newest drugs, newest investigations. But are we able to practice them? Some of us do. It's good that we are able to do. But can this happen across the country? In a country like India? Because these are the questions we need to ask ourselves before we find the solutions. So we need to have some kind of strategies to do that. So we know about it. I've already mentioned about this, the huge different cost effect and all. These are 10 points that should bother all of us in India. So some of the things that we need to do is, spread health education, explain the importance of controlling the disease, and of course the blood sugar has to be monitored more frequently. And we need to treat simple things like hypertension, lipids and others. How is that possible? I mean, it is possible. I mean, general practicing doctors can do it. Family physicians, GPs have a major role to play. And we need to have our own simple data of our own patients. We are in the process of doing it. A lot needs to be done. So, but how do we achieve it is another big question. So this is a simple slide, where starting from the diet, physical activity, oral medication, monitoring is important. All of us are aware of it. And when we manage about diabetes in elderly, we all know that we don't need to be overzealous in managing the very elderly people. It's very difficult to define who is elder these days, but we always talk about the frailty, somebody who has chronic diseases, who is not too well. Don't try to overdo in managing diabetes. I'm using some strong words so that we understand. And coming about insulin is still an important thing in spite of all the new discoveries that are made, because most of these patients could be in insulin deficiency. So how do we manage these poor patients, rural patients, paying from the pockets? One good thing about this is all conventional insulins have similar glycemic lowering efficacy as analogs. See this strong statement. It's not my statement. It's a statement made according to the science. All conventional insulins, purified insulins that are available, which would probably cost 20% of the other insulins, are equally efficacious. No doubt there are some disadvantages maybe. The timing is important, and maybe the hypoglycemic chances could be more, but even that does not happen if you closely titrate. And we need to first of all make sure that insulin is available. We all prescribe analogs to our patients who can afford it. It's a good thing that patients can afford it or they get it reimbursed. But please remember what percentage of Indian diabetics requiring insulin are on analogs. Just think about it. This is a question to all of you. So we have an RSSDI wheel which you will see. In spite of all the latest guidelines and everything, we still talk about individualizing the management of diabetes. Otherwise, it's not possible just to blindly follow ABCD. I always said we are different and our actions should be different. We are different in so many ways. Our genes are different, our habits are different, our eating, everything is different. So what should be our approach? We need to screen people, early detection, which we are all trying to do. RSSDI has moved on. While continuing the research, we have moved on to the area of creating public awareness, screening people in all aspects. So we need to at least focus on some patients who have family history, who are already overweight, and prevail on them to change their habits. And also remember, we need to provide affordable and individualized management and continue to focus on their eating habits apart from physical activity. It's not that, once they come, it's not that you talk about the eating once. Each time they come, you have to ask them. And then remember, you have to provide affordable treatment to most of these patients. Otherwise, they will run away from you. Remember this point. You may be very happy prescribing one of the latest medicines to a wrong patient. If the patient can afford, it's fine. Otherwise, they just simply go away from you. Go to somebody else who might even prescribe a bad medicine. So when you have an opportunity to see a patient has confidence, he has come. So try to keep up the confidence of the patient with you. Try to understand the patient. Try to understand the socio-economic status of that patient and treat accordingly. That's all. That's all is required. We need that much of wisdom apart from following the guidelines and doing all that. I was surprised a small country like Singapore, the Singapore Prime Minister has gone out of the way to involve all the non-governmental organizations and social organizations, religious organizations in his country. They said, you guys prevent diabetes, talk about diabetes everywhere and manage. Our government doesn't do it. Our government doesn't believe even in the professional organizations. I remember when me and Dr. Makar, Dr. Sanjay, when we met our Union Health Minister, we were telling him about incidence of diabetes amongst the poor people, which is very important. We need to work. So the primary care physicians have a huge role to play in diabetes care. First of all, the question is, who is a primary care physician? Is a general practitioner? Probably that's what I mean. So we have a role to play, the physicians and endocrinologists. We need to see that in these situations, we need to see that we train them, conduct some programs for them through IMA somewhere. They become more confident to manage diabetes. Remember, diabetes is not so difficult to manage. I may call myself as a diabetologist, which I am not. It doesn't really help. It's okay. I mean, anybody can treat diabetes. I'm saying this. I'm literally saying any doctor can treat diabetes in most of the situations. And most of the situations mean we are winning over diabetes if our GPs start treating confidently, safely our diabetes. So we have a role to play. RSSDI has a huge role to play. But Sanjay knows it. I'm sure he's already thinking about it. And we have some simple drugs in the
9 inches.
what is called national, even WHO said that essential medicine, national list of essential medicines, NLEM. But government of India has formulated this, where, have you seen this lady? You don't need to be a doctor, of course, to check the blood glucose, even to check the blood pressure in this country. And of course, our research also, why not focus on simple issues? I know we have some great researchers here. Dr. Nihal is here. So I'm sure, Dr. Nihal, you agree with me. You are working in a public institute. A lot of work has been done, which is relevant to India. I'm so happy. But we need to continue it and probably do more on these aspects. The time is, we are losing the time. Don't wait anymore. So we have a significant disease burden with all the complications. Primary care physicians have to be empowered, not only manage, even prevent the disease. So also remember, most of the diabetic patients are treated by the private sector, and some of them do go to the government. So public health initiatives are very, very important, which should be done by the government, by all of us. Some of these simple drugs, which I mentioned, national list of essential medicines available, which can take, and only thing is they must know how to prescribe it at right time. Metformin, simple sulfonylureas. And so we have to treat our GPs how to use sulfonylureas, which are perhaps the most effective anti-diabetic medications. But there are issues with it. I always say, start with small dose, be careful, don't suddenly increase the dose. So metformin is available, glimepiride is available in many primary health care centers, but they must know how to use it. And there are insulin, simple insulins. We must make sure that our doctors don't shy away from starting insulin to their patients. You can't send a patient to a specialist in the town or metropolitan city or to so-called tertiary care government hospitals where people wait for hours together to just have a glimpse of a doctor for a minute or two. So a GP could have started insulin very easily, one of them if you teach a basal insulin or whatever. I don't think it's a big issue. So moving on for another few minutes about type 1 diabetes, which is a huge challenge for us, because we know we have quite a number of type 1 diabetes. The issues are most of the children consume high carb food and they hardly take any proteins. Remember, I am focusing only on the poor children. And I have, in my last 25 years of exposure to these type 1 diabetic children who belong to poor socio-economic status, I was surprised to see that these are the thin guys, people who are almost undernourished, and they require huge dose of insulin. So sometimes I wonder whether the insulin is not stocked properly, what's happening. But then I realize it's happening to many of my patients who require 150 to 200 units sometimes to manage their diabetes. So it's very difficult to explain the consequences of type 1 diabetes to an illiterate parent. It's not that easy, and there are many of them. There are lakhs of children in this country who are not properly managed. Many times parents have many issues, they have issues. You want to focus on the diabetic child, but he has another 2-3 children to take care. The mother and father work out, so they hardly focus on the child. And then the teachers in the school need to be informed, sensitized. And remember, many times you talk about taking an afternoon dose of insulin, and half of them don't take. Those who go to the government school, especially the girls, they're not even toilet there. There's no privacy for them to take the insulin. So remember, this is a statement that I am making in the year 2022 in India. So I always say, who should treat type 1 diabetic children in India? Is it pediatric endocrinologist, pediatrician, physician, general practitioner? Actually, you should reverse the order if you ask me. It should be the GPs, physicians, and pediatrician, then endocrinologist, then pediatric endocrinologist. When it comes to the rural, semi-urban children who cannot afford, I am not generalizing it to everyone. So you see this kind of children with type 1 diabetes who actually succumb, and of course, blood glucose checking is one of the best things that happen to these children. Some of these children surprisingly become very confident. The children that you are seeing are from not from rich background, but they are very confident. They learn by the time they are 14 or 15 years. They even are ready to speak to the media and tell about the implications of diabetes and talk I feel very happy when I see about this slide that we don't want any child to die without insulin. And if you see this, have you seen this lady wearing this? She's even checking the blood pressure. Why not? This is possible. If you train some of these health workers, they can check the blood sugar, they can check the blood pressure. We can have meetings like this. I was telling the other day that one of the greatest inventions that took place in the sphere of diabetes monitoring is not CGMS, it is blood glucose monitor, which was not available 20 years back. Glucose monitor, blood glucose, glucometers are one of the greatest inventions according to me. You can check blood sugar of anybody. You can diagnose diabetes. You can manage diabetes. Both doctors, self-management. So I always tell GPs, just keep a glucometer. You are adequately equipped to manage most of the diabetics. And provided we are ready to train them. So this is what is happening. So these are some of the type 1 children of mine who always have some programs, and they enjoy meeting each other because they develop so much of connection between each other. Apart from learning, they enjoy meeting their friends. So thank you, friends, for the patient hearing.